Chiang Rai Regional Hospital, Thailand. I am a co-chairman today. I would like to open the session, free paper aorta 3 for ASCVTS 2020.
Let's start with the first topic. We have 10 minutes per each paper. And I think we have 8 minutes for presentation and 2 minutes for question. Let's start with the first paper. Treatment strategy and outcome of infected thoracic aneurysm. Dr. Toru Ishimine from Okinawa Chubu Hospital.
Thank you. I'd like to talk about treatment strategy and the outcomes of infected thoracic aortic aneurysm. No disclosure. Infected thoracic aortic aneurysm, ITAA, is a rare but life-threatening disease. The aim of this study is to evaluate early and late outcomes of treatment of ITAA. Between 1993 and 2018, we reviewed 12 patients with ITAA, and the mean follow-up period was 32 months. This shows diagnostic criteria of ITAA: clinical presentation, laboratory findings, radiological findings on CT or MRI, intraoperative findings. We diagnose ITAA based on a combination of these factors. This shows our treatment strategy. First, based on the patient factors, just like age, comorbidities, general condition, we decide whether the patient is suited for open surgery. And if the patient is a good candidate for open surgery, we perform open surgery. And for other patients, if the endovascular surgery is possible, we perform endovascular surgery. And for other patients, we treat the patient medically. This slide shows the patient characteristics. The mean age was 75 years old, and 58% of patients are male. About comorbidities, 42% of the patients had diabetes. This shows the details of aneurysm. 6 patients had aortic arch aneurysm, and 5 patients had descending thoracic aortic aneurysm. And 1 patient had both aortic arch and descending thoracic aortic aneurysm. And we found 1 free rupture and 2 contained rupture into lung. This shows the result of cultures from blood or operative tissue. Organisms were detected in 10 cases, almost 80%, and negative culture in 2 cases. Among these 10 cases, Staphylococcus aureus was the most common, followed by Streptococcus pneumonia and Salmonella Clostridium species. Based on our treatment strategy, 7 patients underwent open surgery, and 2 patients underwent endovascular surgery, and 3 patients were treated with medical therapy. And this shows the details of open surgery. 5 patients had aortic arch aneurysm, and 2 patients had descending aortic aneurysm. Among 7 patients, 4 patients underwent surgery within 1 day from diagnosis. And we basically perform total arch replacement and augmented flap for the patient with aortic arch aneurysm, and descending aortic replacement to the descending thoracic aorta aneurysm. And only 1 patient died of cerebral infarction post-operative day 5. And during follow-up, we cannot follow up only one patient, and out of 5 patients alive without a major complication. This slide is the details of endovascular surgery. The case 1 had descending thoracic aortic aneurysm, and case 2 had distal arch aneurysm and descending thoracic aortic aneurysm. The reasons for choice of endovascular surgery were active pneumonia, advanced age, and multiple comorbidities, just like diabetes or TB, coronary arterial disease in case 1. And in case 2, active endocarditis, cerebral infarction, and multiple ITAA. Both two cases survived to discharge, and during the follow-up, they are alive without complication. This slide shows 3 cases of medical therapy. Case 1 had aortic arch aneurysm, and case 2 and 3 had descending thoracic aortic aneurysm. The reason for choice of medical therapy were advanced age, poor general condition, and TIVA was not available at that time in case 1. And case 2, advanced age and poor general condition, and in case 3, advanced age. And 2 patients died of aortic rupture during hospitalization. And case 3 still alive without complication, just like the recurrence of infection. This shows the hospital mortality by each treatment. As usual, the mortality was very high in medical therapy group, 14.3% in open surgery and 0% in endovascular surgery, 66.7% in medical therapy. About late outcomes, there was no mortality and aorta or graft-related complication among 9 hospital survivors. Early and late outcomes were acceptable in open surgery group and endovascular surgery group. The hospital mortality rate was apparently higher in patients treated conservatively. And although endovascular surgery is known to provide satisfactory early outcomes, late complications, recurrence of infection, and leak have been reported. In this study, there was no late complication in patients treated with endovascular surgery. However, follow-up periods were very short, and we had only 2 cases. So careful long-term follow-up is necessary in patients who underwent endovascular surgery. In conclusion, open surgery is the gold standard in treatment of ITAA. Although endovascular surgery may be useful, especially in patients who are not suitable for open surgery, long-term follow-up is necessary. Thank you.
All right, to make a question. Tadashi Kitamura, Kitasato University, Japan. Very nice presentation, thank you. I just would like to make a few comment and question. I just would like to ask about the endovascular surgery for graft infection. I think it depends on the existence of pseudoaneurysm, whether endovascular treatment is indicated or not, because it's not going to do anything for graft infection itself. And one of the patients who had medical treatment died of rupture. Did she have pseudoaneurysm? And if she did, why didn't you do endovascular surgery for her?
Thank you for your comments. Yes, there are 2 cases treated with medically, and in one case, in both two cases, the finding of the CT that demonstrated pseudoaneurysm. And in one case, because we adopted TIBR in around 2005, and in one case, the TIBR was not available. So that's why we cannot treat with TIBR.
So you mean the patient who survived with medical treatment,
Yes.
he didn't have any pseudoaneurysm, did he?
Actually, the patient who survived with medical treatment has not pseudoaneurysm. Yes.
Okay, so if so, you wouldn't do endovascular treatment for him anyway, would you?
No. We decided for this patient, TIBR is indicated, but the patient and her family refuse this procedure.
But he did not have pseudoaneurysm, did he?
Yes.
He did have.
They did not have pseudoaneurysm.
But you tried to put a stent graft for what?
Basically, regardless of the pseudoaneurysm or true aneurysm, we should treat for aneurysms, infected aneurysms, using TIBR.
Okay, so just to prevent rupture,
Yes.
basically. Okay,
Yes,
thank
I
you
think
very
so.
much.
I have one question. How long will you give the patient the antibiotics after the operation?
For the patient treated with medical or TIBR?
For intervention, any intervention, endovascular or open surgery?
Okay, and for the patient treated with TIBR, I think we should continue our lifelong antibiotics for the patient treated with TIBR and or medically. But yes, for patients treated with open surgery, antibiotics is needed for 4 to 6 weeks after surgery.
Okay, thank you. Congratulations to your great result. Just 10% of mortality is also great for infected aneurysm.
Thank you.
Let's start the next topics, the investigation and management of aortic graft infections. Dr. John Dakins Lee Brooks.
So a wonderful talk from Dr. Ishimini. So what do we do when those infected aortic aneurysms become infected grafts for us? So thank you very much, Chairman, for the opportunity to speak today and share my centre's outcomes of investigation and management of aortic graft infection. So first I'd like to thank my mentors, Professors Bannon and Yan, and it's a pleasure to give this talk today, having been informed by Dr. Peterson, El Khoury and Oshima's talks on the subject the other day. 2 to 4% of thoracic aortic grafts are complicated by infection, and it's a potentially disastrous complication. It can lead to leak, heart failure, paravalvular leak, sepsis, and death, a mortality rate of 25 to 75%. There's extensive guidelines for lower vascular infection, even if perhaps they're not from the strongest evidence base, but apart from some statements from the AHA, no such guidelines are available for thoracic grafts. So therefore, our group sought to extrapolate our experience in investigation, management and outcomes of thoracic aortic graft infection. And now to me, this comes down to 3 hard endpoints for our patients. So mortality, reoperation and reinfection. So we describe a retrospective cohort managed at a single centre, which is Australia's largest aortic centre. We had 45 episodes of infection in 35 patients. We can see their original operations between 1992 and 2018, and representation with infection between 2000 and 2019, that should say, my apologies. A median follow-up of 3 years, excellent rates of follow-up, above 90%. You can see the details we collected there for them. So these are the baseline characteristics at time of representation with infected graft. So average age was 56, the majority was male. We had 7 diabetics, another 5 with other immunosuppressive comorbidities, 5 patients with a cancer history, 8 marfanoid patients, and we can see a reasonable number of dissections, particularly type A, in their original presentations. So these were the previous operations. Obviously, this is more than the number of patients in the cohort, as there are several complex aortopathy patients here who've had multiple stage procedures throughout their ascending arch and descending aorta. The majority being mechanical bentals, but a large number of TVARs and thoracoabdominals as well. You can see their indication for their primary operation, the majority being valve disease with a dilated root, connective tissue disorders with dilated root and ascending aorta, and dissections. So to their infections. As this slide shows, the first surprising but also very important point is the time to infection. This is a large number of late infections. So time to infection greater than 4 years, so 50 months for us on average, with only 6 what one would describe as early graft infection based off the MAGIC guidelines for vascular graft infection out of the UK, only 6 episodes in that first 4 months. The majority had typical infectious presentations with fevers, lethargy, chills, just over 50%. But then we also had a mix of other presentations such as delirium, chest and back pain. These were in patients with significant leak and wound issues and heart failure as alternate presentations. Now, to investigation. So in way of bloods, CRP was a non-specific marker, but very reliably elevated across the board. Average was 199. The range was 50 in a patient who'd had a week of oral antibiotics with a GP treating for a lower respiratory tract infection, but that's still 12 times the upper limit of normal, right through to 550, 130 times the upper limit of normal. White cell count was a little less reliable, increased on average, yes, but only 57% presented with an increased white cell count. Over recent years, we've been increasingly using PET scans to identify graft infection at our centre. So we had 20 recent patients who'd had PET scans performed, all more than 4 months after their original operation. Obviously, PET scans detect infection by looking at the increased glucose avidity and bacterial uptake of glucose around the graft. In the setting of hypoglycemia, this can become more unreliable and obviously can light up for other reasons such as cancer, other causes of inflammation such as aortitis. But within our infectious cohorts, we saw an average SUV or uptake of 11.2 with a range of 4.7 to 16, and 90% of them were above 7.4. The 2 patients lower at 4.7 and 5.5 were both grossly hypoglycemic at the time of the scan, rendering their scan results somewhat unreliable. We additionally also saw a dose response with IV antibiotic management decreasing from on average 13 to 7 in the 6 patients who had monitoring scans with PET scans. Though I will say there's no evidence currently that this decrease in SUV aligns with patient outcomes in conservative management. And it's interesting to note, compared to the current gold standard in general graft infections considered to be the white cell scan, we had 5 in our cohort. These white cell scans missed 3 episodes of infection that were detected by PET scan, and all 3 of those patients at open operation had frank pus around the graft. And this matches the experience of Corselli's group, who found that half of their white cell scans missed aortic infections that were later confirmed at time of surgery. So this is the microbiology of our patients. As you can see, the majority of them are staph and strep, as you'd expect. Obviously, a number of unknown and culture negative results in keeping with the general literature, along with a couple of HACX and other weird and wonderful organisms. This is just breaking it down by gram stain, again, mainly gram positives, as you'd expect, but a range of gram negatives, which were mainly seen in the descending aorta and TVARs. So, port of entry for these, obviously the majority, in keeping with any endocarditis or infected graft series, is unknown. We had 3 at the time of orthopaedic surgery, though in fairness to our orthopaedic colleagues, a couple of these were at the time of trauma. Translocation from the gastrointestinal tract is another important cause, and especially in strep bovis and other particular gut-sensitive organisms, it's important to screen for underlying colorectal cancers. Dental, again, although the NICE guidelines in the UK have moved away from giving dental coverage to patients with valves and grafts. I think this highlights the potential importance of those, and that still remains in the American guidelines to cover with antibiotics at the time of dental procedures. We can see other wound and reinfection issues presenting there. So this is how we went on to manage our patients. So of the 45 episodes, 19 episodes were managed with IV antibiotics only. We can see a mortality rate of 15% in that group and 5% with recurrent bacteremias and recurrent episodes of infection. We can see the washout group, which was accompanied by periods of vac and irrigation or omental flap coverage as well, did particularly well. This group had no mortality, no reoperations, no reinfection, and each of these patients was very reliably taking lifelong antibiotics beyond their time of initial infection. I think this becomes very important for these patients. Within our redo group, despite fairly aggressive resection of infected material, replacement of valves and grafts, we had a 10% mortality rate, which overall I think is very good in this cohort. We had reoperation rate of a further 3 patients, 2 of whom died, and a reinfection rate of 5 patients who then went on to have either washout and omental coverage or only IV antibiotics. As we can see, there was no difference between the groups there in terms of their outcomes. These were the reoperations performed. Again, mainly Bentals, replacing them with a couple of homografts, a few freestyle roots as well. This is overall aortic mortality. It was 14%. We had 6 deaths, 5 of which were aortic, and 1 patient died of metastatic colorectal cancer. So for those who died of aortic causes, 1 died on table, 1 died in the ICU after returning for a redo operation for the leak at their brachiocephalic patch, 1 arrested on the ward after presenting whilst he was being worked up for reoperation, 1 was effectively inoperable and was palliated with sepsis and heart failure, and 1 had represented with a massive stroke at time of reinfection, and whilst having antibiotics to see if he made a meaningful neurological recovery, died from his neurological complications. So this slide really just highlights the difference between regions of the aorta. Overall, a few differences in terms of demographics. This third column of ascending, descending and arch just highlights those patients with complex aortopathy who'd required multiple interventions and in some cases had total prosthetic material from valve to iliacs. But what I really wish to highlight with this slide is the difference in organisms between those. So almost all of our far and away the majority of our gram negatives were in our descending and our TVARs, so likely from groin access, from lateral wounds, entry into the abdomen, with only 1 gram-positive coccus in that group, whereas our ascending and arch patients were almost universally gram-positive cocci. And I think it's one of the key things that we can take away in terms of targeting antibiotic therapy when you have someone come in with infected or suspicion of infected graft, depending on the location of that graft. So to contrast with the other literature available to us, we can see that there's only a very small number of very modest reports. These are the only other studies with greater than 8 patients. We can see the approaches that each of them adopted. Mortality is high across the board, between 25 and 60%. Rates of reinfection vary from 0 in Coselli's group, who was very rigorous on ensuring that all patients remained on lifelong antibiotics, right through to Sandhu's group with a 26% or 25-26% reinfection rate, where only about half of the patients were on lifelong antibiotics. Additionally, reoperation rates sitting about 10 to 15% in keeping with our own. So I think what we really want to look at here is how we're going to contrast this with our just to highlight our numbers again, I think our mortality rate in very complex, very high-risk patients is excellent at only 11%. Reoperation rate low, 6.7%. And our reinfection rate is perhaps getting towards that higher end there at 22.2%. I think speaking to that reinfection rate, at least of those 10 patients who presented with reinfection, 4 were either not on lifelong antibiotics or had been non-compliant with their antibiotics, and there are a couple there as well that records aren't available for. So I think this really highlights where Coselli had rigorous lifelong antibiotics and a 0% reinfection rate. Sandhu, only about half on lifelong antibiotics. I think this highlights the potential importance of a long tail of oral antibiotics in this patient group to prevent the potential disaster of reinfection. And then in terms of use of PET scan, again, only very modest numbers of patients. Going through it all, 26 patients, Tokruta 11. But we can see reasonable SUV cutoffs in keeping with our own of about 7.4. They've suggested 7.25 and 8. And as I said before, white cell scan has been considered the gold standard in graft infection, but in our cohort missed 3 of 5 very clear infections. In Coselli's group missed it. But we're basing all this on very, very modest volumes of evidence, really small patient numbers. And that's one of the key things stopping the guidelines here. So what key messages could we potentially take home from this cohort I've presented, the second largest series of thoracic graft infections too? So there's a much greater burden of late disease than's previously been noted. Ours is greater than 80%. CRP, although non-specific, universally grossly elevated at 12 to 120 times normal range. PET scan, increasingly utilised and increasingly useful with an SUV 7.4 as a cutoff for us. Previous studies suggesting between 7 and 8. And by selecting a tailored management approach, not just deferring to traditional dogma, many patients aren't fit for re-entry for complex redo surgery. Some can be managed with just optimal source control, with omental flaps, with long-term antibiotics. Some can tolerate and definitely need aggressive resections and redo surgery, and by tailoring this approach appropriately, the traditional high mortality can be avoided. And lastly, even with aggressive resection of infected tissue, the risk of reinfection is very real, and I think there's certainly a potential for the need of lifelong antibiotics to prevent reinfection and potential re-disaster in these patients. Thank you.
Any question from the panel? Any question? Congratulations for your result. And I have one question.
Yes.
What's the gap of your choice to treat the patients with aortic graft infection?
Our choice, I think, is very much shaped by the patients. I think if you see the patients who have large volume leak, who have paravalvular leak, poorly controlled sepsis despite optimal medical therapy, I think these are the patients who really need aggressive resection because they're without other option. If you have those patients who come in who have some early signs of infection, but on scanning have no free gas around their grafts, don't have gross valvular involvement, and respond well in the first few days to antibiotics, I think those are the patients that you can get away with either just giving a washout to if there's perhaps collection there without any gross leak, or if there's just uptake on the graft without any other anatomical deficits, who you can get away with managing with IV antibiotics. But then to some extent you're also shaped by what this patient's history is. I mean, some of these patients coming in, you've got one of the ladies in this series is now a 90-year-old in a nursing home who'd had a previous type A dissection, who was never going to be fit for redo surgery or consideration of a restenotomy. So perhaps there you're caught that your only choice is IV antibiotics. So I think overall the consultants at our centre take a very pragmatic approach in terms of the patient in front of them, their septic state and their anatomical deficits in terms of what we have to do for them. But certainly in recent years I'd say more and more we've been doing just washout no mental patches where there's no valvular deficit or leak.
Any question? Thank you for your excellent presentations. We move to the next topics. The preoperative neutrophil-lymphocyte ratio predicts bleeding tendency during elective total heart repairment. Dr. Tadashi Kitamura.
Thank you, Mr. Chairman. I have no COI to declare. Now, in the previous studies have reported that coagulopathy during cardiovascular surgery is highly affected by inflammation. And NLR, or neutrophil-lymphocyte ratio, is a parameter of inflammation, and it can be easily calculated by routine hematological exam. The objective of this study is to investigate factors for intraoperative bleeding in first-time elective total artery replacement. This was a single-center retrospective observational study, and review of patient records were performed, and lab data obtained within 3 days before surgery were used. The surgical technique of total artery replacement included moderate hypothermia, lower half-body circulatory arrest, and selective cerebral perfusion. And as a parameter of bleeding, 3 factors were investigated. First one was post-CPB time, which was defined as time from termination of cardiopulmonary bypass to completion of surgery, which is considered to reflect time required for hemostasis. And the second factor was the amount of intraoperative blood loss. And third factor was amount of intraoperative red cell transfusion. Results. From April 2011 to September 2019, a total of 79 patients underwent first-time elective total artery replacement in our hospital. There were 59 male patients, and the mean age was 72 years. 10 patients were on preoperative anticoagulation, and 26 patients underwent concomitant procedures. The preoperative NLR mean value was 2.8. The mean operation time was 440 minutes. Mean cardiopulmonary bypass time was 226 minutes. And the mean post-CPB time was 143 minutes. And mean blood loss was 1,300 mLs. And the mean red cell transfusion was 860 mLs. And 16 patients out of 79 finished the operation without red cell transfusion. There was one in-hospital mortality, which counted for 1%, and 2 patients underwent re-exploration for hemorrhage. And the factors investigated for the association with bleeding factor were age, sex, body weight, and aortic pathology, that was true aneurysm or dissection, fusiform aneurysm or saccular, or existence of murothrombus. And preoperative antithrombotic medication, including anticoagulation like warfarin or DOAC, or antiplatelet. And preoperative blood data, including hemoglobin, neutrophil count, NLR, platelet count, INR, fibrinogen, albumin, creatinine, EGFR, AST, ALT, LDH. And operation data, including concomitant procedure or CPB time. These factors were investigated for association with the bleeding factors. And age, sex, body weight, preoperative anticoagulation, preoperative blood data, including NLR, hemoglobin, albumin, EGFR values, and CPB time, were significantly associated with at least one of the 3 bleeding parameters which was mentioned before. And by multivariate analysis, anticoagulation, NLR, EGFR were significantly associated with post-CPB time. And again, NLR, CPB time were significantly associated with the amount of blood loss. And preoperative hemoglobin level, NLR, EGFR value were significantly associated with the amount of intraoperative red cell transfusion. The mean NLR value was 2.8, and if we set the threshold of 3.5, if you have higher NLR, the post-CPB time was longer by 39 minutes. And you will have a larger amount of blood loss by 686 mLs. And you will have a larger amount of red cell transfusion by 663 mLs. To summarize the results, preoperative anticoagulation, higher NLR, and lower EGFR were associated with longer time required for hemostasis. And higher NLR, longer CPB time were significantly associated with larger amount of intraoperative blood loss. And preoperative anemia, higher NLR, lower EGFR was significantly associated with larger amount of intraoperative red cell transfusion. So in conclusion, in first-time elective total artery replacement, higher preoperative NLR was significantly associated with a longer time required for hemostasis and a larger amount of intraoperative blood loss and red cell transfusion. And therefore, for patients with high preoperative NLR, that was 3.5 or greater, low threshold of transfusion and early administration of blood products may be reasonable to avoid bleeding complications. Thank you very much.
Thank you for your excellent presentation. Any question from the panels? Any question? Thank you.
All right.
Thank you. We move to the next present.
Next presentation is simple. Redo proximal thoracic aortic surgery with peripheral cardiopulmonary bypass and minimal dissection. The presenter is Tetsuro Ushida from Yamagata.
Yamagata University from Japan.
Okay.
Thank you, Chairman.
Yes.
Today we present entitled Simple Redo Proximal Thoracic Aortic Surgery with Peripheral Cardiopulmonary Bypass and Minimal Dissection. We have the COI. At first, proximal aortic reoperation, including aortic root, remains challenging with an increased mortality compared with the first-time operation. Second, for successful redo aortic surgery in a patient with complex pathologies, the surgical procedure and CPB, cardiopulmonary bypass, CPB, should be simplified as much as possible. In patients undergoing redo proximal aortic operation, retrosternal adhesions or close contact of the aortic aneurysm or the pseudo aneurysm were often observed. In this slide, representative computed tomographic images are showed. The rupture of these aneurysm or pseudo aneurysm leads to catastrophe. Our objective of this study is to evaluate the results of proximal aortic reoperations with our strategy. Our strategy of redo proximal aortic surgery is consisted of peripheral CPB without central cannulation in combination with minimal dissection of surgical adhesion of previous surgery. The detail of our surgical strategy is showed. In patients with severe retrosternal adhesion, peripheral CPB is established prior to sternal reentry. Arterial cannula is placed at both axillary and femoral arteries. Venous cannula is inserted to both jugular and femoral veins. In patients unsuitable for jugular vein cannulation, axillary vein was used as an alternative. Under decompression of heart, with the aid of vacuum-assisted venous drainage, reduced sternotomy is performed. Basically, left heart venting is not performed, especially in patients with low cardiac function. In order to avoid ventricular distension, vent tube is inserted to the apex of the left ventricle through the lateral means-thoracotomy. Dissection of previous surgical adhesion is limited to the proximal aortic region. The heart itself left undissected. We performed proximal aortic reoperation in 5 patients with our strategy. There were 4 female and 1 male with mean age of 66 years. The indication of reoperation were pseudo aneurysm of aortic root in 3 patients, pseudo aneurysm of the aortic cannulation site in 1 patient, and development of a dissecting aortic aneurysm in 1 patient. The initial diagnosis included Stanford type A aortic dissection in 4 and coronary artery disease in 1 patient. 4 patients diagnosed with aortic dissection underwent either hemi-arch or total arch replacement, and One patient underwent CABG as an initial surgery. One patient had a mediastinal infection. The types of reoperation were repair of pseudoaneurysm in 2, thoracic replacement in 1, valve-sparing root replacement with thoracic in 1, and bent-over procedure in 1 patient. The interval between the initial surgery and reoperation ranged from 2 to 214 months. Preoperative computed tomographic image showed retrosternal adhesion or a close contact to the pseudoaneurysm and an aneurysm of ascending aorta were noted in all patients. Peripheral CPB was established prior to sternal reentry in all patients. Arterial cannulation was conducted on both the axillary and femoral arteries. Femoral venous cannulation in combination with jugular or axillary vein cannulation were performed. The left heart was not vented, except for 1 patient required vent tube placement through left meniscectomy. Vacuum-assisted venous drainage was performed in all patients. Antegrade selective cerebral perfusion was employed in 2 patients for arch replacement. Result of CPB is showed. Mean operation time, CPB time, and cross-clamp time are 488, 279, and 130 minutes, respectively, are a little bit long. Excellent decompression of the heart was achieved without left heart bending. The sternum was opened with an oscillating saw and adequate cardiac decompression. Catastrophic rupture during sternal reentry did not occur in any patient. The cooling and removing phases were managed well without any technical problems. All the surgical adhesions were not dissected completely. A suitable surgical exposure could be obtained. As shown in these photos, there are no cannula or only 1 small cannula in the surgical field throughout the surgical procedure. There was no operative and in-hospital mortality. All patients showed good post-operative recovery, and there was no recurrence of pseudoaneurysm and infection in all patients. The detail of our strategy and procedure were published last year. In conclusion, satisfactory full-flow CPB was achieved with peripheral cannulation and with the aid of vacuum-assisted venous drainage. A suitable surgical view of the proximal aorta was obtained without dissection of the heart. There was no operative mortality, and the peripheral CPB was well managed without technical problems. Thank you for attention.
Congratulations for your excellent result and your great presentation. Any comment from the floor? Yes, please.
Thank you for your presentation. I'm Shin from the CCIT Thailand. I have 2 questions. One question is we need jugular vein cannulation for the all cases, so the femoral vein is not enough for the. And then second one is how about the cardio pressure for the heart? What kind of cardio pressure you use?
At first question, the modern femoral cannula for minimally invasive surgery, called MIX, is usually provides a sufficient venous drainage. As you say, the jugular cannulation is not needed in all cases, but we inserted venous jugular or axillary venous cannula in cases to obtain adequate venous drainage. And second question, what is second? Sorry.
How do you do the
cardioplegia?
Yes, cardioplegia.
Cardioplegia is inside sometimes under ventricular fibrillation, we open the ascending aortic graft and directly infuse selective antegrade cardioplegia. And sometimes we systemic injection of potassium to systemically.
So during the cases, you keep using the selective antegrade?
Yes. Retrograde cardioplegia was not used.
Okay, thank you very much.
Thank you for your great presentations. Any question more? Yeah. As we move through.
Thank you very much.
Yeah. Here, the next topic is early and late outcome of proximal aortic repair after the repair acute type A aortic dissections. Dr. Atsushi Omura.
Thank you, Chairman. Backup. My presentation is regarding proximal aortic surgery after the acute type aortic dissection. With the improved surgical outcomes of acute type aortic dissection, the number of patients requiring secondary surgery, such as aortic valve regurgitation or false aneurysm at the proximal sources, has been increasing. So in the presentation, we report our surgical outcomes for this aortic pathology. During October 1999 to December 2019, 444 patients underwent surgery for acute type aortic dissection. Among the hospital survivors, 30 patients who required a radio aortic operation is retrospectively examined. The mean age was 67 and male gender is 13. And the extent of graft replacement at the initial surgery is hemorrhage repair in 20, partial arch in 1, total arch replacement is 1. Also, total 3 patients had reimplantation procedure concomitantly. This slide shows the main causes of reoperation. Progressive aortic valve regurgitation is major cause of redo operation. The patient is 16, and false aneurysm is 8. Pure root dilatation with tissue cutting is 2. And the other infectious endocarditis is 3, and hemolysis is 1. The interval between the first and the second operation is 59 months. And this slide shows distribution separated by each etiology. It seems no significant difference. And as a first surgery, our standard proximal repair is basically a double-felt sandwich technique. And as a surgical sealant, we used GR glue until 2011, but now we used bioglue routinely for proximal aortic reinforcement. And the second surgery, we managed to preserve aortic valve if aortic valve deformity did not exist. For example, sufficient geometric height, or there are no commercial detachment, we try to preserve it. So let's look at the surgical modes in each etiology. For progressive aortic regurgitation, We performed the isolated AVR in 5 and AVR with partial remodeling and the non-colonic cusp in 4 and ventral in 5 and reimplantation 2. Over 85 patients has used of GR glue at the initial surgery, and the most of patients AR was possible due to the valve deformity caused by unhealed commercial detachment. And next for false aneurysm or root dilatation, we perform the resuture in 3, ventral in 1, and reimplantation in 6. All patient, but all patient in all patient, aortic regurgitation is within moderate. So we preserve it. GR-related tissue necrosis invaded aortic root, but aortic valve was intact. So we can successfully preserve aortic valve in 6 patients. And for infectious endocarditis, we had 3 patients, but definite cause of infection was unclear. And lastly, there were 1 hemolysis. The possible cause of hemolysis is blood flow was affected by the inner felt. So from this event, thinner and soft Teflon felt or short length of dark long graft is basically used as an inner reinforcement. This slide shows the operated data. The operation time is over 500 and CPP time is mainly over 200 minutes. That is a long operation. And also 25 patients had required this operation, such as a total arch replacement. And the patient, we lost a high-risk patient who had end-stage renal failure and post-operative intestinal necrosis, but our outcome is acceptable with 3.3%. And the major major complication is low. So during the follow-up period, survival at 5 years is about 82%. 2 patients require 3rd operation, but 1 patient with reimplantation required 3rd operation due to mainly mitral regurgitation. But the others, 7 of 8 patients with reimplantation, AR, the grade of AR was within mild and good healthy condition. So last slide, I would like to conclude. Proximal disease might be associated with GR toxic side effect, and patients who receive the GRF should be carefully follow up than the other. Radio proximal aortic operation is a complicated operation, but the early and late surgical outcomes were acceptable. Preservation of aortic valve might be a reasonable option if aortic valve deformity did not exist. Thank you so much.
Thank you for your excellent presentations. Any questions from the panel? Do you still use the BioGlue for the root repair now?
Yeah, no, we don't use GR glue, the toxic side effect, and now we use the BioGlue or routine use. Yeah, not use fibrin glue because the adjacent is I think a little bit weak is for the fibrin glue, so we use the BioGlue.
Have you experienced in the patients with a very small aorta? I have some patients have their aorta less than 20s, and sometimes we put the double Teflon techniques. I found that the lumen remains a small lumen to remain. It's like aortic stenosis sometimes.
Unfortunately, we have one patient that we show the slide. That's aortic hemolysis is caused by the sorry, due to the felt strip. But unfortunately, we have only one patient.
In the last case, I tried to do adventitious inversion techniques for the proximals.
Sometimes a complicated procedure for all surgeons. It's sometimes surgical demanding, technical demanding. So basically, we use double felt sandwich technique.
Any questions from the panelists again? Yeah, thank you for your presentation.
Thank you.
Let's move to the next topics. Yeah, the early outcome of the first 50 cases of worsened irrelevant tongues, a single center experience. Dr. Ngoc Phai Lucius Lee.
Thank you. Good morning, and I'm Lucius from Premier Hospital in Hong Kong, and we would like to share our experience of our first 50 case of full elephant trunk operation. Sorry. Yep. So since 1983, the powers already described the use of elephant trunk, and then Cato in 1996 described the use, firstly described the use of stent graft, and since then more and more people are using it, and then gaining more popularity. And nowadays there are multiple commercially available full elephant trunk that we can use, and the most popular one would be the Jotia Evita and also the Forafest multi-branch graft. And so actually, the advantages of full elephant trunk already well mentioned by many authors previously, including facilitating second stage repair, eliminate the endo leak, and is a durable exclusion of the forced lumen flow, and also can promote distal aortic remodeling. And the international guideline already suggests a class 2 recommendation for the full elephant trunk in various aortic pathology. And so our study is to present the early outcomes of our first 50 cases of frozen elephant trunk, and it is collected prospectively in our database at our center. And so here is the demographic data, and we start our program since 2014, and there are 50 cases, and with a mean age around 56 and male predominant. 3 patients were Marfan syndrome, and 60% had a preoperative diagnosed to have hypertension, and 10% have DM, and 4% has chronic lung diseases. And actually around 1/4 of patients had previous open heart operation, and among those 8 of them actually had previous ascending aortic replacement for the aortic pathology, especially the type A aortic dissection. So here is the indications, and actually 24 of them had acute dissection, and 17 of them had chronic dissection, and 9 had aneurysm. And the presentation was half and half, and half of them were performed electively, and then half of them were underwent emergency operation. And here are the operative details. Majority of the patient had a Forafest branch graft full elephant trunk in this cohort, and 36% of the patient had associated procedure, for example, CABG, AVR, even root replacement or subclavian artery embolization for aberrant origin of the subclavian artery, or extra anatomical bypass of the axillary artery due to the dissection. And the mean cardiopulmonary bypass time were 249 minutes, and the aortic cross-clamp time were 148 minutes, and circulatory arrest time were 69 minutes. We routinely perform the axillary arterial cannulation in all dissection cases, and we also employed selective antegrade cerebral protection, and we usually cool the patient down to around 24 to 28 degrees. Initially, we performed zone 1 to zone 2 distal anastomosis, but in the recent or in the last 10 cases, we moved from zone 1 to zone 0. And in the early cases, especially in chronic dissection, we also employed the use of a guide wire and also angioscopy to guide the full cerebral deployment. So here is the operative photo showing we are using the right axillary cannulation, and then the other cross cam here, and also the antegrade cerebral perfusion catheter. And here is the operative photo. The left up image is when we open up the aneurysm, and then we put in the device, and then the lower left is we usually perform the distal anastomosis in the interrupted Paget sutures, and finally we will anastomose the aortic branch. And so we here we can see that we usually snare it, and then with a selective antegrade cerebral perfusion, and in this case we also perform a CABG as well, and we usually in some cases we may use one of the branch to the air. So here are the results. The in-hospital mortality was found to be 8%. 4 patients died, and 1 died from pneumonia, 1 died because of multi-organ failure, 1 died because of sudden death, and 1 suffered from uncontrolled massive bleeding. For this case is a patient who is a Jehovah's Witness and with a quite a complex aortic pathology, complex type A dissection, but we still perform the salvage surgery for him, but the bleeding cannot be controlled, and he denied any kind of blood product and also blood transfusion, and therefore he finally succumbed, unfortunately. And the mean hospital stay were 30 days. And for the morbidity, the major complication happened in 12 patients, and among 24%. The stroke rate was around 2%. Bleeding occurred in 5 patients, and there were 2 patients having paraplegia, and 2 patients had a vocal cord dysfunction, and 3 had a chest infection requiring tracheostomy, and also 3 patients requiring dialysis, and 2 patients had a thromboembolic event other than stroke. For example, the kidney infarct and also the intestinal ischemia. So when we stratify the outcomes by the diagnosis, and actually what we can see here is that the general impression is that the chronic dissection the patient with chronic dissection actually may perform badly in our cohort. And I didn't include the statistical analysis in this table because of the small numbers, but this may be due to the fact that we perform the full cerebral trunk for the chronic dissection early in our series, and there may be an issue of a learning curve, and also there may be the issue of inadequate sizing of the full cerebral trunk related to the dissecting aneurysm size. And for the survival, 1 patient lost his follow-up, and the mean follow-up time was 23 months, and there were 3 late deaths, and the first year's survival was 95.6%, and the mean survival were 47 months. And for the 3 late deaths, all occurred in patients with a chronic dissection, and actually 2 of them died because of a rupture of the distal thoracic aorta, and 1 patient died after second re-intervention of the abdominal aneurysm, and due to pneumonia. And when we stratified the result by the diagnosis, and the chronic dissection group also performed badly, as shown in this survival plot. So this table just summarized the literature available looking at study including all aortic pathology, and actually our result is similar to those to the international to other international centers, and the limitation of our study is that it is actually a heterogeneous cohort, because many of the previous study actually just look at the BK1 dissection, and however in this study we include all kind of all patients with aortic pathology, and this is only an observational study without any comparison, and also just 50 cases, which is just a small numbers of cases, and it is hardly to draw any meaningful conclusion at this time point. And also we are now in the process of evaluating the aortic remodeling, because in the literature there are some authors suggesting distal remodeling by measuring the aortic caliber, the degree of thrombosis, but we are still doing that, and also the long-term result is still pending. And so, ladies and gentlemen, in conclusion, and from our early experience of full infant trunk, this kind of extended repair in treating aortic dissection, aortic aneurysm, be it acute or chronic, is still feasible and safe. And even in acute aortic dissection, it is associated with satisfactory clinical outcome. Thank you.
Thank you for your excellent presentations. Any questions from the panelists? Any questions? I have 2 questions.
Sure.
One question, how do you measure the aorta for select the stent part of first in trunks for acute? First.
Okay, for acute, actually we don't measure. We just use the smallest full infant trunk size in our stock, because we would like to prevent or avoid the distal sign, it's stent-induced new re-entry. And in our cohort, even because maybe the Asian people having a small body size, even with smallest, usually we use a 24, 26, and 100 millimeter thoracic graft for them, and no any problem for acute dissection.
You use the same size in
every patient, 24, 26, and 100.
Yeah, not
in acute setting.
Yeah,
yeah, in acute setting.
Okay, yeah. And for the chronic?
For the chronic, of course, we have to look at the 3D multiplanar reconstruction, and we actually measure the size. But I would say it is quite difficult, and hence, we encountered 3 cases or 2 cases of late death in the chronic dissection group, which present with rupture. And so I explained previously, this may be due to the inadequate sizing, because we don't want to oversize too much to make a new entry or make it worse. But we measure multiple levels, but we still don't have a consensus how to measure it. Then any expert opinion about the measuring the size, or is it?
I think that for the chronic, it's very difficult.
It's very difficult, yeah.
Some doctors suggest to use the 2 lumens oversized, and some people
one only. Yes.
I don't know which one is.
Yeah. Me too.
Yeah, thank you.
Thank you very much.
Yeah.
And I would like to close this session. Thank you very much for all panels and presenter.